I just need to send the link to Ian Log.
Hello.
Ian, welcome. Hiya.
Hi.
It's Ricky Bell. Hi, Ian.
Oh, hi, Ricky. You all right?
Yeah, good. How are you?
Okay. Sorry, we've had a bit of a trying to get this sorted on this end.
No, MS Teams is never straightforward. Don't worry.
Okay.
His date of birth is 25/28/1997. The test number is S3284297.
Okay, I can share screen, so that should kick off.
Yep.
Can you see all right?
Yeah, can see that. So just to introduce, everyone, very grateful to have Ian Loke here today, who's one of the cardiology consultants based at the Glenfield, who's going to be talking to us about heart failure. Ian, I'll hand things over to you. Thank you very much again.
All right, thank you very much for asking me to speak. How many people am I speaking to roughly? I have no idea.
So we've got about 13 people, but then I think there's potentially more people over at the Royal.
No, that's great. And so most people's at what level, sort of registrar, consultant level? Okay. Cool.
It looks like a mix of both, and then potentially, some sort of core trainee level, maybe in the room and at the Royal as well.
Okay. Just gonna find whether is this the loudest it'll go. This struggling to hear anything.
Yeah, it's really
All right.
really good pronunciation.
I really have to help you to just step away so I can hear the screen properly. Yeah. Okay. So I'm happy to take questions. It's probably at the end will be a bit easier just because of the team's business. But save up your questions, because there will be questions, and that's what I'm here for. So thanks very much. I'm going to start. I'm one of the heart failure consultants. I run the heart failure service in Glenfield. I've been doing it for a while, and I feel like a man in a trench. What we're going to do today is talk about a little bit about what heart failure is, because things have moved on a little bit over the years. Talk about what tests to do, pre-op, optimal drug treatment. So what's the latest kind of stuff that you might come across when you see these patients? And the last bit is probably a bit contentious. I'm going to try and talk about pre, peri, and post-op management of heart failure patients. And that I'm aware I'm probably an idiot in this world, but there you go. This will be my take on it. So what's heart failure? We always say it's primarily a heart problem. Okay, the heart can't deliver what your body needs. At the end of the day, it's a clinical syndrome of signs and symptoms with a primary cardiac problem. So that means heart failure is not an echo report. I hear this and it makes me irritated straight away. The echo shows heart failure. No, the echo shows a heart that doesn't work or works or has a leaky valve. It doesn't show heart failure. Heart failure is a clinical syndrome. That's the starting point. And we always talk about HFrEF and HFpEF. Now, I hope all of you are aware of HFpEF. Yes? I'm looking in the room, what, four people? Yeah, have you met the HFpEF patient? Are they irritating to look after? Yeah, they're incredibly irritating to look after because primarily heart is like a diagnosis of exclusion. So you're saying this patient has heart failure with a pump that works well. It's like saying this man has lung cancer with a chest X-ray that's normal. All right, and essentially you can give almost anyone HFpEF. If you take an 80-year-old patient with diabetes and hypertension and you gave them lots and lots of fluid, they will develop fluid overload, pulmonary edema, and you can say I have a HFpEF patient. Okay, and it's also incredibly common. So it's very hard to know when this patient has HFpEF or not. And certainly for the anaesthetist, I think it's particularly challenging because when you look at a patient and they come into the room, they're a bit breathless and they've been labeled as heart failure and the echo shows normal LV function, what do you do then? And you're going to get a lot of patients like that. And the problem is when you look at the heart failure population, if you look at all these patients with heart failure, you're going to find about 30% have a reduced ejection fraction. When we say reduced, we talk about 40% and under. That's kind of the current thinking, 40%. Okay, you're going to find some have definitely HFpEF, so normal ejection fraction. So that's over 50%. And then you've got a small proportion which are kind of in the middle, which that's wrong. That's an old slide now. It's called mildly reduced ejection fraction heart failure. Okay, why are we being pedantic? Are we just doing this to be irritating and try to make life difficult? Well, it's because all the drugs that we have for heart failure are primarily low ejection fraction heart failure. So whenever people talk about drug treatment, okay, even device treatment, it is almost always reduced ejection fraction heart failure. So for half the heart failure population, we don't have any treatment for, which is a bit sad. So when you say, please optimize this patient who has HFpEF, I'll say, go away. I cannot optimize them. There's nothing to stop, nothing to give. Make sure they're on diuretics. That's about it. Okay. But going back to HFrEF has moved on in time because when I was a houseman in '94, we used to admit people for ACE inhibitor trials. Happy days. Can you imagine clocking a patient like that? Yeah? Come in, blood pressure every 2 hours, and you go home. That's why it was easier in the old days. Okay, we will work harder, more hours, but we had easier patients. Right? It's a piece of piss kind of admission, isn't it? And you would never start an ACE inhibitor on a 70-year-old very aggressive. Way too, you can't. And people with heart failure tend to die. So you didn't have them for very long either. You don't have these very complicated 85-year-olds who come in for a hip operation because they will be dead. They got the MI at age 60 and they will be dead by age 65. Right? But all these drugs that we have in front of us, beta blockers, ACE inhibitors, MRAs, spironolactone, they all extend life. They really make people live longer. And currently this is what we talk about when we say the heart failure pyramid, or what's the other one? Okay. Oh, they call it the Fantastic Four, and some people call it the foundational building blocks of heart failure, the four elements. So we've got our ARNI at the bottom, which is Entresto or an ACE inhibitor. So that's one big group. So you're probably very familiar with Ramipril being the main one. Okay, lisinopril is old-fashioned. Then you've got the ARBs, candesartan, losartan, but that's been all superseded by the super ACE called Entresto, sacubitril valsartan, which came out about 5 years ago, which is better than an ACE. And most patients these days who are sort of well-optimized, medical, modern stuff will be on Entresto. Okay. You've got the beta blockers. That hasn't changed since the mid-90s. Bisoprolol, carvedilol. You've got your MRAs, which is spironolactone. And you have your last one that's come out about 3 years ago, SGLT2, so dapagliflozin and pegliflozin. So those four drugs put together are what we would like all our heart failure with reduced ejection fraction patients to be taking. Now, why are we so obsessed about all this? I mean, the thing is, the purpose of drugs is to do these things, to make people feel better, okay, to make them live longer, and the last one is to make ourselves feel better. But it's very hard for us to do nothing. Okay, even all anesthetists are just as bad as the rest of us, aren't we? Well, I don't know. Maybe you're not that helpful generally. All right, but medics otherwise, we try to do something. All right, and all the drugs that we have make people feel better. It's amazing, even beta blockers. So every time I tell, and people are always surprised, the ACE. I told this to some, was it GPs? There's an ACE inhibitors help people feel better, and they were like, "Really? Does it?" Yes, it does. They all make them feel better. Okay, beta blockers. Some people feel a bit worse, but by and large, most of them feel better as well. All right, they all help you live longer as well. So if you're on a drug, you're more likely to live longer. Of course, they make us feel better. this is what happens. So if you look at patients with heart failure at any age, okay, that's what happens in the US. At any age, in any group, the heart failure patient is more likely to die than if you don't have heart failure, right? So these drugs are not just for fun. They help people live longer, and also they help people feel better. So if you think about it now, we were always taught at med school that heart failure is a chronic condition, chronic long-term condition. How many patients who, if you came to me now today, severe LV, ejection fraction 20%, okay, what do you think, if I can get you on all 4 drugs, what do you think your likelihood of recovering heart function is after a year? Have a guess.
40?
Yeah, 40 to 50% will get better heart function. Not just feel better, not just stabilize, you will actually get better. 40 to 50%. It's amazing, isn't it? All right. So it is no longer a, oh, you're doomed. Because you hear this on the world all the time. This man's got 30%. Oh, 20%. And I get patients, they did an echo in the community. They were rushed into hospital. What's the ejection fraction? Is 20%. They walked in. That's not a terrible patient. Okay. These patients can do very well for very long on the right drugs. All right. And this is what happens if you get a 55-year-old on all 4 drugs compared to just the ACE and the beta blocker. So ACE and beta blocker is good 90s style stuff to gain an extra 6 years of life. Okay, I think the second one is clearly BS, isn't it? You can't make an 80-year-old gain 2 years of life because 80-year-olds die anyway. This is just statistical manipulation by the very clever authors. But there's no doubt that if you're on all 4 drugs, you feel better, you live longer. So we always fight to get them all 4 drugs. Turning direction slightly. HFpEF then. So HFpEF is my friend and my enemy. It's very common. So when I started in med school, I was told if you have normal ejection fraction, you don't have heart failure. Okay. Then when I became SHO, they said yes, there are some people with heart failure and the ejection fraction is normal, but they're just generally fat women with fat legs. Right? When I became a registrar, they said, well, these fat women with fat legs, they have some breathlessness, there's not heart failure, but they don't die. They're much better than the ones with reduced ejection fraction. All that was clearly nonsense. Okay, they die just as much, they're just as sick, they come to hospital as much or even more than HFrEF. Okay, and it's getting more common. They're getting more common because these are patients who have survived everything else. And if you survive your UTI, your chest sepsis, your pulmonary embolus, your hip operation, they will eventually get vascular end stage stuff. And this is what HFpEF is. It's a stiff old heart. And it's often the result of lots of things. It's not just, the heart is the primary problem, but there's lots of stuff. Of course, you've got your cellular level stuff, stiff, scarred hearts who just don't work very well. You've got your kidneys, you've got your vascular stiffness, the aortal distensibility, the right and left heart compliance issues. You have your lungs. Often they have some lung disease, COPD, asthma, fibrosis. They often are very unfit, the skeletal muscles. The kidneys are usually rubbish. They've got diabetic changes. So these are just old patients with stiff hearts and a tendency to collect fluid. And we label them as HFpEF. And the problem with HFpEF, of course, is diagnosing it's very difficult. It needs lots of stuff. If you're in America and you're insured, then you can get lots and lots of unnecessary tests. We don't do them so much in this country. But this is how we diagnose HFpEF. We say, one, you've got to have symptoms, you've got some edema. Usually you have an abnormal BMP. And the third thing is your echocardiogram shows good LV function, but something else that's wrong. So very rarely will you have a HFpEF with a completely normal echo. They've got to have something. Big atria, pulmonary hypertension, atrial fibrillation, something. You can't have a normal echo. And it's important to recognize HFpEF because nothing works for them. So this is a slide that shows. So you know these things. If your bar is to the left of the midline, that means it works. If it's to the right, it means it doesn't work. If it crosses, it means it doesn't work. So look at HFpEF. Depressing, isn't it? Beta blockers, ACE inhibitors, we've tried them all. The only thing that almost worked was aldosterone antagonist, which won't bore you for reasons. It was just badly done trial, but it could have worked, should have worked. But there you go. So even Entresto, the wonder drug for HFrEF, they tried it, didn't work terribly well either. Okay, so essentially HFpEF, nothing works very well. And when you look at all the guidelines, this is what happens there. If you've got HFrEF to the right in red, all this stuff you can do. Look at that: ACE, beta blocker, hydralazine, nitrates, Entresto, ivabradine, and what's the ICDs? First ICDs, CRTs, my red wouldn't stretch that far. Okay, but HFpEF has this bit. That's it. Okay, and this is despite this group being as much as common as HFrEF, 50-50 split. There's a drug that came out, so I put this out in a blaze of optimism. Oh, new dawn, but NICE rejected it because it's not cost effective enough. So even the new drug has gone, it's a damp squib. It's a very depressing state for HFpEF. Right, so let's talk about what you guys do for a living. Okay, heart failure in patients having anesthesia. Okay, and we know heart failure patients don't do very well. So they're more likely to die. They're more likely to have complications. And I didn't realize this till I did this talk. The tendency to come back to hospital with problems much higher if you've got heart failure. Okay, this is a big sort of American sort of registry that looked at thousands of patients, so fairly robust data. And the problems are in all operations, so you can't blame just the orthopedic anaesthetist for doing a bad job. Every group seems to have problems. So what do I do then if you have a patient with heart failure and you see them in the clinic, right? First is don't panic, right? And sometimes you can sense the panic. You can sense I'm not pointing fingers, I'm pointing fingers, but you get referrals where they've seen somebody who's a bit breathless, has a slightly funny ECG, and they just say, right, we've got to stop. No way, this guy's got heart failure. We can't operate on this. We've got to move on. Okay, we've got to stop the clock and send him to cardiology. And when you do that, what happens? How long do you think it takes for us to see these patients?
1 minute.
6 months for a new patient now. Okay, and I'll see them, I'll say, okay, we're going to echo. Maybe you've had an echo. That's another 3 months. You start some drugs, 6 months. So whatever problem you've come in with, it's going to be a year of, you've kicked the can down for a year. So it's rather unfair on the patients. So what do we do then? These are the guidelines. Have you seen this before? I'm sure you have. Similar kind of thing, right? Actually, first time for me as a cardiologist to look at stuff like that. It's quite interesting. If you have non-cardiac, if you have emergency non-cardiac surgery, just get on with it. All right. If you have an active condition with active cardiac condition, you got to treat it. So angina, heart failure. You try not to do it if you can. You try to delay it, but you treat it and you get on with it. Okay. If it's low risk surgery, get on with it. And low risk, what do you mean by low risk? Educate me.
Something like a surface surgery or something like breast or something.
But so
Where
often they don't get on with it. So often people
Where
do
there's not
stuff.
much fluid shift.
Yeah, exactly. So why are they doing tests? Do you tell each other, say, oh, if this is low risk, no tests required? Because I'm not seeing that in my practice.
Well, it's not that. It's still worth having the tests, so you know what you're managing. So
Yeah.
you still
Okay.
have to manage a patient with heart failure, even though they're having a low risk. The surgery
Okay.
is not going to do much. The
The
anaesthetic is
anaesthetics.
still kind of.
But the
that
guidelines
straight.
suggest that you don't need to do anything.
So if she has like good effort tolerance, if you feel
Okay,
like
fine. So you've got to, but this seems to suggest that low risk surgery, you don't even need to the functional capacity. You just go straight to do it.
yes, that you just see the meds if it's
Okay,
fine.
but this one, see, low risk surgery. If it's yes, proceed. Does
Yes,
that change?
That was isn't that an
in the
emergency
context
surgery?
of somebody with heart failure.
No, this is just for any cardiac thing.
But
This
But
is
that looks like it's a need for an emergency. If it's an emergency, you just anyway crack on with it.
no, this one's a step 3. So it says low risk surgery. Yes, proceed.
But we still do an anaesthetic assessment. And
Okay,
you
fine.
See, like you said, heart failure can be a clinical thing as well.
Yep.
So
Okay.
for us, it's like, okay, we know this person's got a heart that's maybe a little bit more fragile than somebody who doesn't have
I
heart
get you,
failure.
I
We
get you.
manage them in a cardiac preserving
Yeah.
way when we do our anesthetic.
Okay.
assessment.
So when functional capacity, this might be old. Is this old? Because you guys do CPET now, don't you? More
But-
CPET.
but-
We just ask them, can you get up the flight of steps?
Yeah. So if
Yeah.
you can't determine it, with,
So I looked up what a formats is, and that's what formats is. 2 flights of stairs. So
Yeah,
you get
yeah,
2
yeah.
flights of stairs. You shouldn't do anything else. You stop the clock, don't you? But that's
Yeah.
not what I see.
um,
Is it me?
I think you just get referred the ones. Which are
Okay,
really
fine.
bad
So
probably.
theoretically, if you can do that, that's it. You stop. That's it. You move on. Okay. So when do we have to do things differently? So this is the best I could find in terms of guidelines. Okay. I'm not going to spend too much time, but essentially, if you have heart failure or suspected heart failure for non-cardiac, intermediate, or high risk, then you should assess more. Okay, this is for patients who have established or suspected. All right.
And the other thing to
Right,
note is
sorry.
that with high risk surgery, they often have it's not often the anaesthetic. We can always seem to get people through an anaesthetic. It's
The
the
after.
recovery period and the risk of complications after, the how severe the
Yeah.
pain is, and all that kind of stuff can really affect somebody's recovery. And if they've already got a failing heart, poor functional capacity, then we kind of need to know how far we can push them.
Okay,
this kind of surgery.
fine. I'm being facetious.
No,
You know,
it's
and the
fine.
other side of the fence is always easier to. All right. So I'm sort of the obvious is avoid this. All right. But if you are actually decompensated, everything's bad, and the heart is buggered. So it doesn't take well to any kind of resuscitation, doesn't take well to inotropes. It's just a bad situation. The problem with heart failure patients is they can be quite subtle as well. What's decompensated? Unless you actually know heart failure, it's not that easy. Okay. So often the leg swelling and all that, it can be quite hard. So I'm a big fan of looking at the JVP using an ultrasound scan now. You guys can do that. I taught one of the nurses to do it in clinic. The JVP, is a beautiful tool. I'm a huge fan of this, better than IVC as well. Okay. But lung ultrasound for congestion, more sensitive than chest X-ray. Right. So somebody certainly for acute admissions and you're worried, is he fluid overloaded? Lung ultrasound, JVP, very good assessment for fluid balance. Okay. So who should get an echo then? So if you go back to that earlier guideline, okay, who should get an echo? What do you think? Get a patient in clinic, he's supposed to have heart failure. Less than 4 mets. Okay. So if let's say they're less than 4 mets, but they're known to have a bad heart, would you repeat the echo?
If it's done in past, say, 3 months, or
You should,
maybe 6
yeah.
months, would it?
Okay, let's say they're more than 4 mets. Okay, let's make it easy, harder. More than 4 mets, but they've got a severe LV from a year ago.
For a year ago,
Yeah.
I think I would.
Okay.
I mean, if they haven't had any,
If it's a major surgery, probably.
Yeah. So we often get a lot of echoes requested. And one thing, if you've got severe LV and if you've got heart failure, requesting it's not going to change it. Ultrasound doesn't change LV function. You got what you got.
probably wouldn't if they hadn't had any decline in function. So if they've had an echo a year ago and their functional capacity has not changed and they're still stable from that point, I wouldn't see the point of re-echoing them because you'd still, and if their functional capacity was more than 4 mets but the echo was bad,
Yeah.
functional capacity is what's going to get you.
Correct. So that's, I think that's, I wouldn't say mistake, but that's something I often see. So good function, reasonable functional capacity, but a bad heart. People stop and go, shit. And then they refer to cardiology who can do nothing. I'm not a magician. I cannot make the heart better. Oftentimes, the first year apart, okay, once you've got a bad heart for a few years, it's not going to get magically better. So you can echo all you like, but ultrasound is not actually a therapeutic modality. It's an imaging modality. So you can't, there's no point. You're just delaying things for the patient, especially if you've got a good functional capacity. That trumps it. You're quite right. So you've got a good functional capacity. You've got a bad heart. They've got a bad heart. You've got to play the game as an anaesthetist, but requesting an echo is not going to help. And oftentimes you're going to get funny stuff. That's what we get. So funny valve, moderate LV, moderate MS, moderate MR. What do you do? Doesn't help you, but you go back to the functional capacity because that trumps your echo. Okay. How about BMPs? Oh, this is a blooming Pandora's box. Oh,
I would see them used a lot more commonly more recently.
yeah, but
No.
that's because you guys are kind to me. I'm genuinely grateful because the guidelines have changed, haven't they? The guidelines actually suggest BMP pre-op. ESC guidelines changed last year, but this is even 2014. It was I couldn't find the latest one, but I can tell you it came out last year, and we were like, oh! But thankfully, you guys have. In fact, hopefully, after this talk, you stay the same as you are. Okay. The problem with BMP is it's a good measure of how bad the heart is. Okay. The difficulty is what you're going to do with it, because if you do it, you're going to find a whole bunch of a real spread. You're going to get some very high, and you don't know what to do with it, and there'll be some, a lot of in between. That's the problem. A lot of in between, which doesn't help you at all. So I'm going to talk a little bit about BMP because it is creeping into what we do. Okay, so my thesis was on BMP, so I will try not to bore you, but essentially it's AMP and then BMP. BMP correlates with ventricular stretch. So when your heart is stretched, your BMP goes up. So when you look at a heart failure patient, you've got 3 things we always check. How breathless are you? How are you doing? Second thing we ask is, how's your heart function? What's your LV like? And the third thing is what's your BNP? Because your BNP tells us how well controlled your heart is. So I've got loads of patients who might have ejection fraction of 20%, but their BNP is almost normal because they're so well looked after that they're not under strain. Okay, so it's complementary information. The BNP is quite helpful for me there. And some people, very eminent, much cleverer people than me would say a BNP equates to heart failure more than the heart. Okay, it tells you that they're under strain. I think it's slight nonsense. They're probably a bit silly about it, but it certainly does tell us that something's in trouble when you have a very high BNP. The problem is, it's a continuous variable trying to give us an ordinal result. You get that? Yeah. So you're very clever. You can read that for yourself. You're gonna have false positives, false negatives, and etc. And this is what we see. So when you have heart failure patients, your heart failure with BNP tends to be high, but there's a big overlap with all the others. So and this is what I try and teach people. Look at the trend. So is it getting worse? And by getting worse, it's not going up by 20 or 30, it's going up by hundreds. Okay. Is it very high? So this is old money. So this is old BNP. So more than a couple of thousand is bad. Is it very low? Less than 500 is good. Okay. Some conditions always have a slightly higher BNP, so atrial fibrillation. Atrial fibrillation, you divide by 3. Right. So you don't panic if your BNP is 1,005 with AF. It's normal. All right. And the way you can do that also is you go back. Oh, it's always been about 1,005. Chill. So what do we do then? Anesthetizing the heart failure. Yeah, you walked in the perfect time. I'm going to patronize. No. I get genuinely nervous putting up this slide. Okay. Of course, risk versus benefit. That's bloody obvious, isn't it? But quite hard. Sometimes you see these patients and they really, I feel for the patients with, say, hips and knees, because they're genuinely suffering. They often have some degree of heart failure and they're turned down very easily. They just say your ventricle is terrible, you can't have your procedure. But when they come and see me, the BNP is not too bad. They're on all the right drugs. Okay, you can't assess the meds, can you? Because they're in pain from the hips and knees. But they've been turned down flat because of a bad heart. And I think that's always a difficult one. It's easy if you've got cancer, easy if you've got an emergency life-saving procedure, but it's hard to assess risk and benefit in that situation, in my opinion. Okay, and certainly I looked at trials, and the trial suggested that these patients do reasonably well if they're optimized. Okay, optimizing is the other thing. There are very few trials that tell you if you optimize a patient versus not optimizing a patient, what will happen. Okay, you don't know. All right, and no one tells you how long they have to be optimized for either. Are you optimized for 6 months? Is it better than 3 months? Okay, it's a difficult one. Apart from avoiding the obviously pulmonary edematous patient with leg edema, I cannot find any data anywhere that tells me that if I put a patient on ACE inhibitor for 6 weeks pre-op, they do better than if I don't.
Yeah. With you were saying that heart failure medications aid in remodeling.
Oh, yeah.
Better remodeling,
Yeah.
like remodeling back. What kind of time frame do you take
1
to
year.
see those?
1 year. I usually say I wait a year. Beyond 2 years, it'll be rare for the heart to get better. So if you have got somebody who's recently presented with heart failure, then delaying things by a year is probably a good thing to help give the best chance of the heart actually recovering.
So that might play into the optimizing time frame.
Yeah. But I think a lot of it is more chronic kind of patients. So chronic patients, the likelihood of recovery is pretty low.
So you don't see much remodeling in those then?
If you had an MI 10 years ago, you've got a bad LV now, it's not going to get better after that. You might get a couple of percentage points, but generally it's not going to get better. Okay. I looked quite hard. I don't know, you guys can tell me which is better for patients, which anesthetic technique. There isn't any consensus, is there? I kind of assumed stupidly that spinal is better. It's not, is it?
It's
Something like a
how you
regional.
do it rather
Yeah.
than what you do.
Yeah. And this is dependent on the operator. A good gas boy or a lady. That's what the trials say. Right, it depends on you and your technique. If you're comfortable giving a spinal, then you're probably better than doing the, I don't know. Am I right?
Yeah, you're right.
Okay.
There's not much difference between about 30 days, is there? Like in the moment, like it can be better to do
Yeah.
regional technique if they've got a bad chest. But
Yeah. And as you say, that could help their pain after and all that. So you get pluses and minuses with both. Managing arrhythmia and deciding fluid balance. We've got a little bit more on that slide-wise after this. So pre-op, so we said functional assessment, I think trumps everything. Is that a fair comment to make? Yeah, so I can write back when I get my next referral. Like, kid you not, I have patients. I just had somebody who sent to me, their CPAP was fine, but the LV was moderate. And they said, we will not operate until this patient has had an MRI, and I did all that, got the drugs, and then did the MRI, and then they wrote back to me saying, the MRI shows a big infarct. Are you sure there's nothing else you want to do? I said, yes, there is nothing else I want to do. So sometimes we can be distracted by the results. So this patient, at the end of the day, had a good functional capacity, but has now had lots of tests to satisfy ourselves. CPAP's quite good. Use CPAP a lot. The data is not huge, though, It's not huge. It's kind of an arbitrary kind of thing, and it looks at risk of perioperative mortality and recovery, but it's not like the be-all and end-all as well. But we're using it like a be-all and end-all. Let's put it this way, if you've got, is it 7 the cutoff? What's the cutoff? 11, sorry. So if you hit the cutoff, you're very safe. But just because you don't hit the cutoff doesn't mean you're doomed. Does that make sense?
Yeah, you're just higher risk.
Yeah, high risk, exactly. But we've crept into a little bit of, we can't do it if it's that. And it's not, I don't think the trial suggested that. It was, I didn't have time to go through it in detail, but when I looked at it, I said, oh, okay, it predicts higher chance, but it's not like below that. And again, it's an ordinal, we're trying to have an ordinal value with a variable, with a continuous variable. So it's slightly unfair on the guy who has, say, 10.5. Slightly, okay. So we talked about echo a bit. Ischemia testing, so looking for coronary artery disease, has gone really out of the window. We don't like doing it at all, okay? Because even in the world of cardiology, we've found that just fixing arteries doesn't actually do much for patients. Even when you have terrible heart function, even when you have ischemia, fixing the narrowing doesn't always do anything. So we try not to even look for ischemia unless the patient has symptoms. Right, so we've gone away from just doing angiography, even stress MRI. We've gone away from that. So if the patient has no symptoms, we don't do. Okay, and we talked about BM. Sorry.
Ian, it's Neil Flint over at the Royal. I'm just going to go back to CPAP briefly. I think, that, yeah, you can take the absolute numbers, but actually it gives you a lot more information than that. What it will tell you if you've got, a heart rate limitation. It will tell you if you've got a sort of cardiac output limitation. Yeah. You've got a respiratory limitation. So actually, even though you can use the absolute numbers, and if we ever used 11, we'd never operate on anyone, to be honest, nowadays. But
I agree. I think, yeah.
It will give you a lot of other information about what your limitation is. I agree with you entirely that the whole, functional state is absolutely what you should be aiming for. And I think the only question mostly people should be asking you is there any way we can optimize this patient? What I've taken from a lot of what you said is actually the sort of delta BNP. Actually, it's quite useful. The trend in BNP is useful more than anything else. It's not something that I've really appreciated before. I've got a question for you though. Why are you guys obsessed by ejection fraction when actually it's the stroke volume that's important?
Well, we're obsessed by ejection fraction because that's what all the trials are based on. You gotta obsess about something. That's what the trials tell. That's what a lot of our studies are all based around ejection fraction. And stroke volume varies too much, and you can't measure stroke volume unless you have lots of clever things to do it with.
But of course, you can have an apparently good ejection fraction and a terrible heart.
Yeah, that's what HFpEF is.
So yeah, but with
but the thing is, the ejection fraction is important for us because that's what the basis for most of our drugs is.
So is it just because it was what you used to measure and everyone's used to it that is why you still use it?
Yeah. Well, again, see, it boils down to what drugs we give. So you got to know your ejection fraction as a starter. You want to explain the next slide for me?
Me and my big gob. No. In honesty, I'm not an expert at it. I know some people that are, and I always ask.
I looked it up, and I'm not an expert on this, which is why I hate doing these talks when you venture into an area where there's somebody in the audience who's probably done a PhD on this. But CPAP, as you rightly say, gives us a lot of data apart from the VO2 max. A lot of us, like idiots like me, just go, what's the VO2 max? But actually, it tells you a lot more than that. Where's your anabolic threshold, whether you get a good effort, whether your heart rate response was good, what your lung function was like, what your oxygen consumption was like. So this gives you a whole bunch of things. But it's a very good predictor of overall fitness. Okay, so, and it's a very good predictor of how well the patient will do during the operation and also after the operation. It's a very good predictor for recovery as well, isn't it?
Can I ask you?
Yeah, sure.
What if the patient can't do a CPAP, like somebody
Yeah,
broke
exactly.
their hip or something?
Exactly.
Wouldn't you do a stress echo for that patient?
Well, stress echo wouldn't give you information like that.
I mean, what about how do we look for inducible ischemia, which could occur intra?
Ischemia.
Yeah.
So we don't look for, that's why we don't look for ischemia unless the patient has symptoms. We don't look for ischemia.
If they can't complete the CPAP,
Yeah.
in the report, we'll write that
What
down.
if he can't perform the CPAP because of?
So you have to write why, but if it's because of a disability, there's variation. You can use like arm cycles and stuff. But if you're saying because of cardiac respiratory reserve, they can't do it, that is documented in the report, and it's usually that these patients aren't really, they're higher risk than you would want.
Can you explain this for me? So that's the one on the left is normal. The one on the right is the one that's not normal. I'm not even gonna try. I feel too nervous to do that. Okay, but essentially look at the oxygen consumption and where it changes at anaerobic threshold in the red, and this is normal. It keeps going up, and in there it stays flat. That's how I read it. But frankly, when I do this, I go and talk to a colleague who does them, and I ask them, "What does it show?" Or I ask my transplant colleagues. So anyway, so what do we do pre-op? Immediately pre-op, do we continue beta blockers? There was a debate about this before. Do we? We do. Yeah, we should. But there was a debate about it. It wasn't as clear cut as it was. Okay.
Continue.
Okay. Yeah. That has it gone? Has that gone? That's gone away.
New beta blockers in private stations.
Yeah. Has it gone? Yeah. So there was a bit of a trend for doing it for a while, but that's gone away. And certainly, if you have got AF arrhythmia, you would be foolish to stop the beta blockers. Okay. Do you stop ACE inhibitors pre-op? Yeah. So there's a good amount of data. When I was doing the top 5-6 years ago, there was some data, but now it's pretty. So all my effort to start them on the 8th, you stop them anyway.
Just for the day of surgery.
I know. I'm kidding.
Okay.
Okay. Yeah, but they do have problems with kidneys and blood pressure, don't they? Peri-op. So I'll take the red away. So all of you, is that normal that it all gets stopped? Okay. And during the op, okay, this is more dangerous now. I really should just talk quickly. All right, it all goes to pot apparently when you put them to sleep. That's why we always, when Justin Williams says, "Oh, I'll put them to sleep, I'll kill the peri." I find, okay, yeah, the studies show that. I agree. Everything goes to pot once you put them to sleep. All right. And of course, a heart that's not good is even worse. I didn't realize how much worse it is. And it's quite revealing for me. Also, you can see why the poor heart failure patient struggles. Because generally, your first response, correct me if I'm wrong, you will correct me, I'm sure. When the blood pressure drops, what do you do? Yeah, so with what? So drugs. Okay, or fluid. Okay. And the problem with a failing heart is giving fluids, it doesn't work very well, does it? Because the curve is already on the wrong side. So all it does is increases the pressure, right? And if you give inotropes to stop it, so my next one, there you go. Okay. So pressure goes up much faster in a failing heart. So you might overshoot. So you get a little bit of a rise in pressure, but if you go too far, EDP goes up, pulmonary edema. Okay. And of course, you lose your inotropy when you put them to sleep, and straight away the ejection fraction falls. Right. So now you've got a heart that's not only is it stiff and not coping with fluids, it's also pushing out less. The worst thing. And of course, you guys know about if you give too much inotropes, you get the other way. Tachycardia, less time to fill, patient gets drier. Okay, so there's I don't know how you do it. Genuinely, I'm impressed that you don't kill my patients. Because there's a delicate line about how much to give, and that's why I suppose it comes to a very good anaesthetist doing what they do. I don't think I have much to add. Is there anything you would add?
I think most patients survive spiders because of that.
Yeah, and I suppose that's that. And I suppose that's why when they bleed, that's the worst thing, isn't it? because now the body has lost its normal response to shock, and you're having to replicate the tachycardia and the volume change with a heart that is stiff and weak and doesn't like it very much. And that's where, if you have right heart failure, it's even worse. If you have pulmonary hypertension, it's even worse. Severe TR, even worse. So those patients are really not great for an op. And I don't know why we, as cardiology, we don't really assess them for TR and RV pre-op, do we? It used to be when I was a houseman, we did right heart cath pre-op for MR and all that kind of stuff. These days, we hardly do any. In fact,
I remember having been called, this is up in Hull, been called to the cardiology unit for a patient that had come in. He had severe pulmonary hypertension, chronic severe, such that he was sat with sats of 60 and a PO2 of 4 and talking to us, like really severe. And it was like 2 o'clock in the morning. And the regis said the consultant has asked us to talk to you about ventilating him because he's on 60% oxygen, we can't give him any more. Sorry, that was PO2 of 4 on 60%. And I was like, what are you going to do about his pulmonary hypertension? It's like, oh, there's nothing that can be done. I'm like, no. No, you can chat with my consultant, but no, because we can't fix that with a ventilator.
So reading the literature, what I took away was, if you're not, forget cardiac surgery, it's a whole different beast. But for non-cardiac surgery, a light touch is what they like. Is that a fair point? So as little as possible to get away with. Yeah. All right. So if you slug them with lots of saline and lots of blood, then you'll find that you get the blood pressure up initially, but then the price will be paid the next day. That's what I thought I read. Yeah. And the more more hyper volume expansile stuff, the worse it is for the patient, because the heart simply can't cope with volume expansion at a quick level, right? Especially if it's tachycardic. So that combination, especially fast AF. You've got fast AF, bad heart, and some sort of AS, that kind of thing, even moderate AS. So it's important to look at the valves. If it's moderate AS, it's fine when it's sitting still, but under stress with inotropy, their moderate AS will become severe AS. Almost finished. Got through that bit. Phew. So in the post-op, it's quite interesting. When do you restart this stuff? ACE, beta blockers, and that. When do you start that again? Difficult one, isn't it? Especially if they're new by mouth. No studies at all. Can't find anything. Okay. I think I forgot to say this, but one of the worrying things I would say if you were anesthetist, as a patient on lots of diuretics, patients on lots of diuretics are bad patients, I would say. I didn't find that in the guidelines here, but if I was doing this, I would say, blimey, this guy has needed a lot of diuretics to stay stable. This is a guy who's not well at all. The heart is struggling and needing a lot. And those patients, I would want to start the diuretics quite soon after, because they will develop heart failure. Because we see a lot of patients who have had some minor surgery, then they get stopped, or they get started very late, or they get a lot of fluids, and then a month later they come back in with terrible heart failure. You will never see them again, but they'll come to me and they're dead. Okay, so I generally say if you're on a lot of diuretics, start it as early as you can, because these guys are going to get bad. So this is a real example. This is from the Glenfield surgical ward. You can see day after day the weight's going up, literally day by day. Okay, this stuff, ACEs and beta blockers, I would try and get back on ASAP if you can. Maybe not the beta blocker, but the ACE. Okay, and really important that they're on something when they leave would be ideal. At the risk of trying to get more work for myself, if they're difficult and they've got terrible heart failure, it's probably worth telling the heart failure team, saying, look, this guy came on a lot of drugs, we can't get it back on. I'm sending him out, but you need to make sure they get followed up with a heart failure person to make sure that the drugs get put back on, so that they transit this kind of stress and back to stability. Yeah.
You see them unless they come to ITU. And in ITU, we don't tend to start them
Yeah.
until they go back to the ward.
I know. I've got a horrible feeling that a lot of them go out without their drugs. I know they don't. I know they go out without their drugs. I was actually asking one of the juniors to sort of do an audit on bad hearts going home from cardiac surgery. How many people are put? Both you spend so much time making them better with fancy operations and stuff, and the drugs we've seen, they save lives. So you're sending them home without the drugs that save lives, having done a 12-hour procedure, seems a bit of a shame. But we often pick them up months after and then start the drugs, and there will be deaths along the way.
tend to start beta blockers early. If you don't start ACE, because they're always, a lot of them are on anticoagulants.
Yeah.
Non-cardiac, we're more.
Yeah.
Don't start them. Unless
Yeah.
suppressing reason.
Once I got renal failure.
Yeah.
No.
Well, the old, yeah. And what this is off the good old HFrEF. HFpEF, of course, is just diuretics. Get them on the back on the diuretics. So in a way, the one drug that you don't want to be without for a short time is diuretics. Strangely, it's a drug with the least prognostic benefit. It's an old as the Hales drug, but that's the drug that will get you quickly if you're not on it. If you stop your diuretics and you don't restart, then you're telling the patient, we will see you in a few weeks. But if they needed, say, 80-80 before they came in, they will need 80-80 when they go home. You know, that's the reason why they want 80-80. If you don't go home with the same dose, they're coming back. And that applies to respiratory as well, Katie. All right. Any patient who needs lots of diuretics needs lots of diuretics for a reason. I think I reached the end. I don't know why I keep finding these old pictures of myself. A friend sent it to me. This is how I felt after the junior doctor strike. This is how we feel about the next junior doctor strike. There's questions then. Sorry, I'll be shouting a little bit because I'm conscious that I've got to speak to the mic. It's not like I've got a huge ego and I need to shout at people.
What is the process in the ICU in terms of like with non-cardiac ones that are on inhibitors, or do you just hold off? Because you worry about the kidneys,
Tend
or-
to start as early as possible.
I suppose
Inhibitors may be guided by if there's any deterioration in renal function.
the problem is there's no acute benefit for these drugs. Okay, and it might be acutely deleterious, but there's lots of long-term benefit. And the problem these days is if you leave it off, then the GPs are not going out of their way to start it again. And that's the danger.
I think part of the problem is that sometimes we only have somebody for like 2 days and like
Yeah.
they just come off the iron first, right, we'll let them restart that on the ward, and then because like as an anaesthetist we only have them for like a short window, or even an ICU that goes to the ward effectively, so we might not even know that they've not been restarted.
Yeah.
Like when we rewrite the charts, we might not write it on because it wasn't on our chart, but that's it. It's a good point for us to think that maybe we should be putting them on and just saying review on it,
Yeah.
so they can. So
I think
somebody
certainly
thinks about it.
normal, decent blood pressure, normal kidneys, it will be a shame to not get them on the drugs again. If you've got terrible kidneys and all that, that's a different, that's different. But
is there any guidance about SGLT2 inhibitors? Because I know that we've seen a few people come through on SGLT2 inhibitors and then run into euglycemic DKA. And there seems to be variable things about some people have them stopped when they come to hospital, some people have them stopped while they're ill by mouth. I wondered if there's any consensus.
They're stopped if you've got diabetes. So the SGLT2s are now indicated for heart failure with reduced ejection fraction in both diabetics and non-diabetics. So the non-diabetics, the risk of DKA is 0. So you don't have to worry about stopping or starting. Okay. If they have diabetes, type 2 diabetes, then you should stop them if they're acutely unwell. And that's always a slightly gray zone, but certainly if they're having an operation, that's acutely unwell enough for me. But they often get stopped for other silly reasons. Okay. Acutely, it doesn't make any difference. A lot of the stuff I'm talking about is long-term heart failure stuff. It's great for you to have, but acutely, it doesn't really matter so much. Okay. Doesn't really have much of a magic anything acutely. Diuretic. It's diuretic. All right, so no more unnecessary echoes. You just feel for the patients, and just once you take them off the list, it's months of waiting. I don't know, but I would feel quite sad myself if I was going in for something quite minor and then get stopped because we need an echo, and the echo shows mild LVSD. What do you do then? Then you have to wait to see a cardiologist to give the okay. That's literally what happens in the moment. You got to have it.
I guess sometimes it's a case of we don't know, are they on the most optimum treatment, and therefore getting a specialist opinion, sort of like you mentioned, it ticks our box, but also more importantly for the patient is we've actually tried to make you as well as you can before we know you're going to have potentially a step down in your health because you're having a major operation.
But I think first thing to remember is that functional assessment trumps that. Okay. And secondly, again, we do have no data to say the mild moderates, if they're well, having drugs, does that make them any safer? Not really, as we have just shown. Okay. But it's more for you to be aware that this patient has a heart that's not so good, so I've got to be a bit more careful. But asking us to see them, to start them on a drug, is probably not going to make a lot of difference. You know, if they're functionally all right. So I do think there's some unnecessary delays, you know, in the patient journey. That's a very managerial kind of crap thing to say, isn't it? Yeah. CPET them.
Yeah.
Right. I think CPET is quite a powerful tool, isn't it? Right. But having said that, it's still sort of slightly missing the 11, you know, that you know, what do you do with those? And judging how much you need the operation, I suppose.
I think it's just, like you said, it's complementary information.
Yeah.
Like the BMP, it's complementary
Yeah.
information. So we've got that, we've got a CPEX, which is borderline, but we've got somebody
Yeah.
with really crappy functional capacity, then that kind of adds to, this is very risky. Or if we've got a
Yeah.
CPEX that's borderline, but actually they're functioning quite well. Like, it's relatively risky, but it's probably, will probably get you through.
BMP is a funny one. Inigo's not here. I was hoping he would be around. He started by doing lots of BMP. He's a vascular guy, and he's like, he's told me he's got thousands of BMP of thousands, 2, 3, 4,000. I don't know what to do with these guys. Tell me he's okay. What do I do? I don't know. He doesn't know. He's now collecting them for an audit. I said you need to audit it to find out what happens to these patients. He was quite excited at the start when he was doing BMPs, and then the excitement tailed off after I sort of threw back a few referrals at him. No, stop doing it.
He also act with a lot of his patients.
Yeah. And what just for vascular patients, they all have.
Exactly.
I didn't want to say that, but you're right.
Bad, and then there's like.
In a way, if you look at the patient, you know this is high risk. You don't need to do any tests to tell you how much worse they are.
I guess for risk scoring and sort of ultimate patient decision making, you could argue that you are giving the patient the most up-to-date details and information to make that decision. Because they might turn around and say, well, actually, if there's a 50% chance I might park it, then no, thank you. You know, my toe, chop it off or whatever, might chop it up.
Can help surgical decision making as
Yeah.
well.
Mm.
You have the decision between doing a big operation and a limited operation.
I suppose what we need is actually, rather than moaning about it, we just had the service that would see patients quickly and have the capacity. But because we don't have that, then that's what we moan. That's the NHS in a nutshell. On that happy note.
Yeah.
Right. No worries. And any question? Anything else from the virtual audience? When you leave, you see how many people are just still there. All right. No, but if you leave now, you see how many people are still there. Then you know that they're all just sleeping.
Okay, I think.
All right. Thanks, guys. Bye then.
Thank you very much, Ian. Cheers.
Yes.
Well, that was entertaining.
I don't think people know that you're teaching now, do they?
Hello, yes. Hello, I'm one of the Latif, I'm one of the acute medicine registrar on ITU rotation in LRI. So I just want to present a article on comatose patients' blood pressure targets after ROSC. Can somebody tell me how we share the slides?
You are sharing. You should be.
Why it's not
We can see a whiteboard. It says whiteboarding in progress.
Go back to Teams. Get rid of that. Close that down. Stop sharing. Top left, 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 left. There. Now click on share. And then go to the PowerPoint. Screen windows all tab.
Above.
Up, up, up. Yeah. No, no.
the one.
Yeah.
And then find whichever window you wanted. Here's the window. Go to the window. Now find you.
Might as well just do entire screen, right?
Yeah.
And then just do entire screen and get it. Share. And the bottom.
Click it and then share. Need to click on this.
Then do system audio. Get rid of system audio. We
Should I turn it on? or-
yeah. Click it off. Go to share. Now just go to the screen and find your PowerPoint presentation.
Yeah. And just press the presentation plus the option. That works.
Thank you very much. I'm Casualty, one of the acute medicine registrars. So got this article, which is not much relevant, but to try to make it a bit interesting. It's a Danish study done in 2 tertiary care centers for patients who had a cardiac arrest, presumed cardiac cause, and turn out spontaneous circulation. So they just saw whether the blood pressure targets of 63 or 77 made any difference to the 90-day outcome. So we all know, like, the blood pressure targets are the data is limited for the blood pressure targets after the out of hospital cardiac arrest in comatose patients. And blood pressure is the main intervention after in ITU after cardiac arrest. The patients are in shock. Also, we know the autoregulation of the brain is disturbed after hypoxic injury. So we need adequate perfusion pressure to perfuse the brain and to make the injury less and less. Now the question is what should be the map to achieve adequate perfusion, because if we need a lot of vasopressors, then they have their own implications on the patient. Now, again, the clinical question was in this study, particularly what's the outcome of patients after out of hospital cardiac arrest if they are presenting unconscious to the hospital with the 2 targets of 77 and 63 on final outcome, like can it reduce death or survival, or can it reduce the poor neurological outcome? The study was done in Denmark in 2 tertiary care centers between March 2017 to December 2021. So it was double-blind, parallel group randomized clinical trial. Blinding was done with altering the calibration of the invasive blood pressure monitors. Basically, in a way, the blood pressure monitor will tell the blood pressure 7%, 10% less or 7% higher than the actual blood pressure. So also the study, they randomized the patients based on restrictive or liberal oxygen therapy during their period of treatment, as well as they also randomized the patients further according to the cooling device they use, can be surface cooling or intravascular cooling. The outcome measures were, the primary outcome was death from any cause at 90 days, or discharged from hospital with cerebral performance category of 3 or 4, which means severe disability, coma, or vegetative state. The secondary outcomes were like death from any cause in 90 days, time to renal replacement therapy, and neuron specific analysis levels at 48 hours of randomization, MOCA score at 90 days, modified ranking scale at 90 days, and cerebral performance category at 90 days. Study population including criteria adult 18 or above, out of hospital cardiac arrest mainly presumed cardiac cause, sustained ROSC for more than 20 minutes, and comatose on arrival with GCS of less than 9. Exclusion criteria quite extensive, but mainly out of hospital cardiac arrest with non-cardiac cause, unwitnessed asystole, suspected brain event, acute stroke or bleed, females of childbearing age until pregnancy ruled out with a specific test, and patients in severe shock where blood pressure systolic cannot be brought above 80, and if the patient cannot be randomized in 4 hours of arrival to hospital. The consent was taken usually by the relative or the legal representative. If the patient became conscious later, informed consent was taken from them. If they are unconscious, it can be their next of kin or the medical doctor who has no relation in the trial. If the patient has died, then the consent was not taken. So total of around 1,200 patients were assessed for the eligibility. Around 400 patients, they were excluded after exclusion criteria application. Around 800 patients were randomized. So out of 802, 12 patients, they withdraw the consent at some stage, so they were excluded. So the treatment protocol, patients were managed as usual according to the local guidelines with the discretion of treating physician. The temperature was maintained at 36 for first 24 hours, and patients were sedated and ventilated with the use of propofol and fentanyl, and the temperature control was achieved with surface cooling or intravenous devices, and this was a separate part of the trial. Now, the invasive blood pressure monitoring, that was the main thing in the trial, was done with a specific blood pressure module in a way where the calibration was adjusted and modified so that the blood pressure will be 10% higher or lower than the actual blood pressure. So suppose if the blood pressure, mean arterial blood pressure, was set at 70, it will tell either that blood pressure is 63 or 77. So that will make 10% lower or higher, and it was blinded by the treating physicians. To achieve this blood pressure, the patients were initially given volume resuscitation to get the central venous pressure of 10 millimeter of mercury, followed by, if required, norepinephrine infusion and addition of dopamine infusion with the maximal dose of 10 mics per kilogram of body weight. So the more and more pharmacological treatment the patient required, it was quantified in vasopressor inotropic support. So the more and more score will be higher for patient who is requiring more pharmacological treatment. So the results, just few demographics, mostly males, as you can see, 80%. So total number in higher blood pressure group 393 and lower blood pressure group 396. The aim was to match as much as possible to the demographics in the two groups, so that it can be transparent and the results can be generalized as much as we can. So just comorbidities. And the notable thing here, the characteristics of cardiac arrest. So 86% in high blood pressure group target and 84% in low blood pressure group target. They had a shockable rhythm. A few had non-shockable rhythm, and the downtime was um, every downtime was 21 minutes. Now we can see here how the blood pressure was achieved. So BR means before randomization. So that's the initial blood pressure. The both um, groups came, and then that's the red in high blood pressure group target and green and blue in low blood pressure group target, how the blood pressure was achieved in both groups. And then we can see the difference in these two. So here we can see the dose of norepinephrine or vasopressor inotropic score. So that is norepinephrine or dopamine plus any other vasopressor which was used after dopamine. So you can see in red the higher blood pressure group target, the more and more vasopressors were required. But in lower blood pressure group target, less and less inotropic support was required. Now, the primary outcome in both groups was similar, like 30 death from any cause and cerebral performance category of 3 or 4 was 34% in high blood pressure group target, that was 77 millimeter of mercury, and lower blood pressure group target was 32. There was not much difference in selected secondary outcomes as well. And in terms of selective adverse events, for example, infection, arrhythmia, and seizure, there was not much difference in them either. So you can see the probability of survival at different stages of the trial from 0 to 90 days. So you can see initially maybe up to 15 days it was slightly different but not significant. But after that the mortality was never any different in both groups. So mainly the strengths of the trial, obviously, patients coming with cardiac arrest, which is a well-designed double-blind study performed in 2 tertiary care centers. The sample size was good given the condition, and the results were consistent with the objectives outcomes. There was a treatment separation of blood pressure of 10 millimeter of mercury, and there was definitely a difference in noradrenaline dose used. So also the trial included 3 components to assess the outcome, which is MoCA score, a blood level of enolase, and a cerebral performance category. And also the baseline characteristics were very similar in both groups. But the weaknesses, the MoCA score, because of COVID situation, this study was done from 2017 to 2021. The MoCA score was done on telephone interview, or it was done by reviewing the patient notes. So it is quite limiting the study itself. The mean difference in blood pressure, the target was to achieve the 14, like 63 and 77, but it was only 10.7, which was achieved in this study. And even if it is 10, so we can argue whether this is enough blood pressure difference to see the any outcome difference in these patients. Also, one of the main things, the study was done in 2 tertiary care centers where the patients were these were the cardiac centers. So, and these were cardiac patients purely, because this was one of the inclusion criteria that the cardiac arrest should be presumed cardiac cause. So we know that in most patients having cardiac arrest can lead to cardiac cause. The um, mortality can be low as compared to other causes. Um, as well as the study was performed only in one country, and the um, dopamine was used as a second choice of inotrope, which cannot be generalized. So I think the take-home message again, according to this study, there was no difference in mortality or severe morbidity in patients who are presenting with cardiac cause um, after out of hospital cardiac arrest and in comatose state. Any questions?
Get back to the within the screens and see. What would have been perhaps interesting would, because we're talking about a group that's comatose, but actually that definition that the authors have used is a GCS of less than 8. What we know from the different permutations of the coma score is that that could actually encompass a population that you would expect to have a very favourable prognosis. And what I mean by that is a motor score of 6, E1V1, that would make a classic coma score of 8, for instance. We know from a number of studies that the motor score is very highly associated with survival, and especially a good motor score of that. So was there at any point any kind of breakdown, if you like, of any differences between coma scores, and did the authors even look at that as a possibility? Because you could assume perhaps that those with the lower coma scores would be the ones that may benefit more from closer blood pressure control.
I don't think it was seen in this study. It was not part of this study.
And what lessons can we take from this particular study to our all-come population here within the accident and emergency department, considering that a number of our patients will not have had an arrest of any kind of cardiac origin? Are we still back at square one, or is there some messages here that we can take away?
I think at least we can say that there is no difference in achieving the blood pressure between 63 to 77. So
my counter to that is in a population that would be expected to have a slightly better outcome.
I think, of course, this is debatable because this is just one part. The patients who are coming with cardiac arrest, most of them had primary PCI and stuff like that. But it all depends on comorbidities, patient age, their previous functional status, and downtime as well. So, and also, again, the coma status. But in this particular study, they didn't do the sedation hold for at least 24 hours, which was something, I mean, not in clinical practice. Like it's a clinician decision when to do the sedation hold, but still, we could have done sedation hold a bit earlier in some patients, especially if somebody had successful primary PCI. We have achieved ROSC, but initially they were comatose. Instead of putting them on ventilator for 24 hours just to maintain that blood pressure and temperature, maybe we could have done the sedation hold. I don't know.
Was there any population? Was there any description within the article about patients? Because we talked about those with a cardiac origin and those that were presumed to have had cardiac origin. Was there any suggestion of any numbers of patients that went on not to have had a cardiac origin to their arrest?
Those patients were excluded basically. So most of these patients, like 50% in both lower blood pressure and high blood pressure, they had a successful primary PCI, and the rest of them, like 60%, in them even most of them had angiogram done. and
Yeah.
they didn't need primary PCI. So they may have some other cardiac cause like arrhythmia or something else, but they didn't classify it as non-cardiac. So basically, they didn't put any non-cardiac causing cardiac arrest in this study. So that's why we cannot generalize it, because obviously
Sure.
it is just one part, but it may be relevant in ITUs like Glenfield where we have more cardiac arrest patients, or in some center where they have only.
That's what I'm thinking, that perhaps the results of this may be more generalisable to the population and the demographic represented in Glenfield,
Yes.
and not necessarily here.
Yeah, yeah. But overall, according to the English Ambulance Service, the UK mortality is 27% for patients who present in shock rhythm, and in this study it was 31%. So there is a very, that is
I think
local.
that it could be equitable and
Yes,
comparable, directly comparable.
but that is again shock rhythm. They didn't include all the cardiac, so that is little bit tricky again.
Sure. Just wondering if anyone else has got
Sharing.
Yeah, is anyone else
See if
got
anyone's
any?
got their hand up.
Yeah.
Go to the. Check the chat. Next questions. Anybody online got any questions?
Hello, any questions from anybody? I think maybe they are not.
Okay. They've probably just forgotten to log out. So what you need to do is you go, thanks very much everybody, goodbye. Don't leave. Yeah.
Thank
See
you.
if they leave.